Thank you, Doctor. Good afternoon, everybody. So I'm working with Professor Radhakant Padi for the last 5 years on the Indian Institute of Science. So our work is like we are trying to bring whatever technologies we use in aerospace engineering to algorithms for artificial pancreas systems. Because there's a lot of closed loop systems that are being developed in robotics and aerospace. There's a lot of closed loop systems that are being developed in aerospace and in robotics. So we're trying to bring those algorithms into automatic glucose regulation. So I'll just give a brief overview about what activities we've been completed over the last 5 years. So firstly, before coming up with an algorithm, we want to see how the system behaves and whether you can mathematically model the system. So the first thing we did was we collected a lot of data and tried to fit mathematical models for Indian type 1 diabetic patients so that we can exploit the model later on for the algorithm development. Once we had the model ready, we moved on to the algorithm development. We have a model predictive control algorithm, as Dr. Basu has talked about before. And once we had the algorithm, we had to integrate it into a system. So the approach we chose was we'll take commercially certified pumps, commercially certified sensors, and then tie them together with smartphones so that basically we'll build a whole system around them. So that way, the ethical committee clearance, at least we can evaluate the algorithms first before going into indigenous development. So we took a Medtronic pump and a freestyle Libre sensor and tied them together with a smartphone. So that's how we made a closed loop system. We've done limited clinical studies as well as a lot of in silico validation and computer simulations to validate the algorithm. So I'll just talk about the algorithm aspect of it first primarily. So the key components of any algorithm are like as I said before, the modeling aspect. Basically, you want to see how the system behaves and whether you can mathematically model it. Then another key information for any closed loop system is the sensor information. What comes as feedback. So as you know, the sensors are pretty inaccurate in some ranges. So we wanted to come up with a method for correcting the sensor measurements either with either finger prick data or IV glucose, like whatever data is available. So we came up with a method for correcting the sensor measurements that will last for a week or so. That includes the time delay, the bias, and the bias is not constant. It's a time varying bias. We came up with a method for correcting the sensor bias as well. And then once we have the information for feedback, we came up with an algorithm for estimating the insulin doses necessary to maintain the sugar levels. And finally, another key component is something called state estimation. So as you know, glucose is not the only parameter that's inside the body. There are a lot of other parameters that are interlinked, right? But you can only measure glucose. So using the glucose measurements from the CGM, can we really estimate the other states? Like for example, what is the insulin level in the blood? So we're able to estimate what is insulin level in the blood from our CGM data that is corrected. So that is the information that we are going into our closed loop algorithm. So these are the primary components of the algorithm. There are other aspects to it too, but these are the primary aspects. So starting off with modeling, mathematical models, there are two types in this glucose insulin dynamics. One is a high fidelity model and one is a control oriented minimal model. A high fidelity model is basically to create a virtual patient so that you can test your algorithms in the computer environment before you go into clinical trials. Dr. Basu was talking about the FDA approved T1DM simulator. That is a high fidelity model that can be used for evaluating an algorithm before going into clinical trials. So that model was built based on like a bunch of a huge amount of Caucasian population's data primarily. So with that, we can say, okay, this is how a person behaves throughout the day, from morning till night. Given any dose, given any meal, how does a person's response have? We can monitor the person's response in the computer environment. So, but the problem with that type of model is it's very computationally expensive to run, and also it's not feasible to implement it for an algorithm because you need to know a lot of information about the model to be customized to each individual patient. Dr. Rita mentioned that every person's physiology is different, so it's not really possible for the model to be like one size fits all. So you have to estimate a lot of parameters for each patient. So that's why the idea for a control-oriented minimal model came about. The minimal model is basically a simplified version which can be used for short-term predictions, and it's also computationally efficient. So basically, like it'll have like around 8 states. So it'll cover three components basically. First is like if you consume food, how does the food finally get absorbed in the intestine, and how does it appear in the blood as sugar? That component is covered. Second is when you deliver insulin subcutaneously, how does it transport itself through the subcutaneous layer to the bloodstream? What is the delay associated with it? That is also covered. And finally, how is the glucose and insulin in the body interacting? That component is also covered. So these three components are covered in the minimal model. That is what we're using it for our algorithm development. So what on the left side, what you see is what you're using it for algorithm development, and the right side is what is used for evaluation of algorithm. So this is how we are splitting up our models. So our work is primarily on the left side, the control oriented minimal model. So now that we have a model, the model's parameters themselves are patient specific. So every patient's parameters will be different. So how do we identify the patient parameters? So we put them through a mixed meal tolerance test basically. So we admit a patient overnight. We give them like 80 grams of Ensure Plus, and we give them like zero point 0.2 units of 0.2 units per kg of body weight subcutaneous insulin, and then see the response. We'll collect IV glucose and IV insulin data, plasma glucose and plasma insulin data at these timestamps. So once we get a response, we'll be able to fit the mathematical model to this patient's particular data. So you can see that this is the insulin data. You can see how the model fits exactly to that patient's own blood samples. Similarly, we fit the same data for the glucose as well. So now that we have these two databases, we can customize the model for that particular patient. So now that we have the model, we can use this model for our closed loop algorithm development. So we've done 47 such trials to identify how the Indian patients' responses are varying when they're given 80 grams of Ensure Plus or zero point 0.2 units per kg body weight of insulin. So now that we have the model in place, then we moved on to the closed loop algorithm development. So our algorithm is something called a constraint-based predictive algorithm. So if you look at the currently existing algorithms, some of them are PID and some of them are predictive. A PID is something that's a reactive algorithm. Basically, it'll just take into account what is currently happening and the past data, but it doesn't take into account what might happen in the future. So since we have the model in place in our case, we can exploit the model to say, okay, for this particular patient, what is going to happen in the next 2 hours? What is going to happen in the next 90 minutes? Based on that, can we take corrective action right now? In addition to the predictive capabilities, it also has other constraint handling capabilities. Basically, like you can ensure that if you set a higher bound and a lower bound, upper bound and a lower bound for glucose, you can ensure that the glucose values stay within the bound throughout the 90-minute window. So we can do constraints for glucose, and we can also calculate knowing that this is the capability of any device. For example, if you use a Medtronic pump, it can deliver insulin at a rate of 1.5 units per minute. So can you really enforce that component into the algorithm as well? So our algorithm has that capability as well, where you can take into account the hardware restrictions of the device and put it into the algorithm. And primarily, the main USP is it's a patient-specific algorithm. Every patient's computation will be different. For two patients, if they have the same amount of glucose values at any given time, it is not going to give the same insulin. It will take into account what is that person's specific response. Based on that, it will predict forward in time and then compute. That's how the algorithm is written. This is a representative case for a bolus cycle. So we're not giving one-shot boluses. We are distributing the boluses over a time window so that you take into account what is happening every time. So every 5 minutes, we'll keep on checking what is happening, and then give distributed boluses, not just one-shot bolus. So all the patient has to do is enter the amount of carbohydrates they're having around 20 minutes, 15 to 20 minutes beforehand. These are few simulations that we have. Disadvantage of this method is it is very heavily reliant on the model. One more thing we noticed, we all know that is that there's something called intra-patient variability as well. Suppose you fit a model on day 1, that same model may not be valid on day 2 or day 3, right? So how do you account for the patient's day-to-day variability? So for that, we have two ways of handling it. So we'll use the CGM measurements to learn how the patient's physiology is changing from day to day. That is learned every 5 minutes. Every 5 minutes, based on your response, we'll compare the model's prediction, we'll compare the CGM's past data and say, okay, this is the difference in the model. We'll keep on trying to track the changes in the model and keep on learning it. So if you look at this plot here, so the blue line represents the patient on day 1, the red dotted line represents the patient on day 3, for example. Our algorithm should be able to track what is happening from day 3 onwards because it should keep changing, right? So we have an adaptive learning capability where the patient's parameters are being tracked constantly. But then another challenge is, like, there are, as I mentioned before, there are other states in the system. There are other parameters that need to be tracked. How do you account for those? So what we do is, instead of taking one computation, we'll account for the worst case scenario and compute like 9 different scenarios and compute which one has the best case, least amount of risk associated with the patient. We'll compute the same for the same insulin dose. We compute it 9 times, accounting for like various uncertainties, and then select which one is going to be the best one for that patient and implement it. We'll test it for different initial conditions. We'll test it for different patient perturbations, and then ensure that the glucose values are within bounds. If you look at it here, you can see that the upper bound and the lower bound are like set at 80 and 240. So the algorithm ensures that the glucose values are within this range for the entire duration of the bolus cycle. This is the trials that we did for the bolus part. As I mentioned before, the information that is needed for this is the CGM. So now how do we account for the CGM correction? We either use the finger prick measurements or the IV data that is collected from the previous trial to correct for the sensor errors. So if you see here, the red line represents the IV glucose that is collected during the MMT, and the blue line represents the raw CGM data from the freestyle Libre. So during the hyperglycemia part, there is a huge error. So we're able to correct the error as well as correct the time delay associated with the measurement from IV to subcutaneous. So this is how we are using the information for our feedback. Before using it for feedback, we're correcting it and then using it for our feedback information. Once we have this feedback information, as I said before, there are other things associated with it. We'll also estimate what is the insulin level in the blood that is active, then take corrective action. Because if there is already too much insulin in the body, it might lead to hypoglycemia in the future. So we'll try to do corrective action for that as well. So now that we have the algorithm in place, we were able to implement it in certified devices. Like we'll use a smartphone first, and then we used a Medtronic 722 for the previous trials, along with the Freestyle Libre. So this is how the entire architecture is structured. We'll have a front end that connects to the devices, and the back end of this smartphone app will also have the algorithm aspect of it. So we tested the algorithm at a few clinical trials at MS Ramaya Hospital in Bangalore. This is for the morning bolus cycle. So you can see that the bottom plot tells you how the insulin doses were distributed. The target was set at 120 mg per dl for the entire duration of the bolus cycle. This is how we're able to control the glucose levels for the bolus cycle. We done 13 such trials, but this was only done for the bolus part. We're currently working on the phase 2 where we're trying to do basal, bolus, exercise modeling, and various other aspects. So this was in 2022. After that, we had a little bit of funding pause. So during that time, we did other development with the T1DM simulator that Dr. Ananda Basu talked about. It was an FDA approved simulator that can have a bunch of virtual patients that you can use that can be used for algorithm development. So it has around like 10 different patients. The version that we have has 10 different patients, which you can use for like control algorithm development. But then it's primarily based on the Caucasian population. Based on this, excuse me. Based on this, we try to do both a bolus as well as a basal simulation study. In our case, the basal update is every 20 minutes. Basically, it'll check for the glucose values every 20 minutes and update the basal rate. Whereas if it's a bolus cycle, it'll update the values at every 5 minutes. This is just a representative case to show how the glucose level is within control for the entire 24-hour period. So we thought about how to make the AP a little bit more advanced. So we came up with how do you separate different modes for AP, not just basal and bolus. Can we really have sub modes? So first, what we did was instead of exactly entering the carbohydrate value, we thought about putting it into 4 categories. That way, the patient doesn't really need to know what is the exact amount of carbohydrates they're having. This way, it removes the error of estimating. Plus, it's also a little bit more robust because there's only 4 choices. So if you have a carbohydrate range of 1 to 20, it'll just take an average value of 10. So the patient can declare they're just having a small meal or medium meal. That makes it simpler for the patient. And coming to the basal modes, you know that the glucose production in the body changes depending on the time of day as well, right? So how do you categorize the basal modes depending on the time of day? We came up with the 3 windows. One for the dawn effect, where the glucose levels rise from around 3 a.m. to 7 a.m. A different target for the basal daytime, and a different target for the basal overnight. Basically, like we saw that overnight there are tons of hypoglycemia for most patients. So we need to have a higher target range for glucose. This is how we're characterizing the basal rates based on the time, whereas the bolus modes are characterized based on the quantity of the carbohydrates. So now that we have different modes of operation, how do we transition between modes? Because every patient's window may not be the same. For basal example, like the overnight window may be different for patient 1, maybe different for patient 2. How do you transition between those different modes, right? So we have used something called an IMM filter. It's called an interactive multiple model filter. That filter will tell you which mode is more probable at any given time. For example, if it's 3:30 in the morning, it'll tell you this patient is more likely to go into this dawn effect at 3:30. The same patient may be different at day 2, right? So this IMM filter is actually inspired from aerospace, where you're using it for estimating what a target is doing. So that is where the idea came from. So we're trying to implement it here to estimate what is a mode that the patient currently is in, whether his glucose is rising or whether it's falling. So that is how the mode operation happens. Yeah, this is primarily from missile guidance. Finally, we tested our entire algorithm in a T1DM simulator. This is 10 patients for 30 days. We tested it for model uncertainties. We tested it for inaccurate meal categorization, unannounced meals, sensor errors, different initial conditions. And our overall time range was around 80.2% for the simulation setting. So currently we're working on like making it into a clinical trial, so we can test in clinical trials. So our current activities are like we are trying to do meal estimation based on images as well as voice. So it'll be difficult for patients to estimate what what the carbohydrate content might be. So they can just take a photo of their food and it'll estimate what is the carbohydrate content, calorie content, or they can just read out what they're going to have. Based on that, it'll estimate what is the carbohydrate content. Another aspect we're working on is like how do you account for the effect of exercise, whether it can go into hypoglycemia or it can lead to a glucose rise. Can you really use heart rate measurements and step count? Is it sufficient to estimate what the effect of exercise is? Another thing we're working on is like we want to eliminate the need for a smartphone because smartphones can be hacked into, and plus they're not really like made for this purpose. So we're making a dedicated device that can do the computation and can come on the insulin pump directly. That is something we're also working on. And parallelly, we're also collaborating with Amrita University to build a cost-effective pump. That pump has already been animal tested, and it's already in the phase two of the phase two design is currently ongoing. And we're also doing extensive testing currently in the next phase of the project. Currently, all our trials have been done at MS Ramaya in Bangalore, but in future we'll be working with Dr. Mohan's clinic in Chennai and GIMS Noida as well for our clinical trials, where we'll be doing basal control as well as AI-based meal estimation. So these are clinical partners in our journey so far. Dr. Mohan and Dr. Anjana from Dr. Mohan's clinic, Dr. Saurabh and Dr. Payal Jain from GIMS Noida, Dr. Chitra and Dr. Pramila from Ramaya, and Dr. Bipin Nair is the one who's heading the pump development. And our mentors are Dr. Ananda Basu and Dr. Rita Basu. They've been helping us with the protocol finalization, how to go about the clinical trials in the closed loop setting. This is our journey so far. So hoping to continue in the next 5 years. Thank you.